Hi, everybody, and welcome to Healing and Inflammation. So, you've heard the term many times over. What exactly is inflammation? It does carry a bit of a negative rap, but in fact, it's actually a positive thing, and we couldn't do without it. So, inflammation then is considered as a non-specific defense or defense response that the body does a response to when it results when we anytime we have tissue damage. So it is a non-specific defense response of the body to any form of tissue damage, or if the body perceives that there is tissue damage. So what can produce this kind of response? Pathogens, so a virus, bacterial infection, that kind of stuff. Abrasions, so any damage done to for example, the skin, you fall off your bike or something like that. Chemical irritations could be serious chemicals such as cleaning products around the house or in industry, all the way to things you might be using inside your house, or even a moisturizing cream or something like that that's got something in it. Distortion or disturbance of cells, so any kind of impact or pressure, those sorts of things. Anything that disturbs a cell can result in an inflammatory response. And extreme temperatures, so anything that makes the tissue way too cold or extremely too hot will also elicit an inflammatory response. In other words, inflammation is an attempt to dispose of microbes, toxins, or foreign materials at the site of injury. Again, perceived injury by the body. Inflammation also prevents the spread of these foreign materials or microbes or toxins from heading out into other areas of the body. Remember, skin, if we're using skin here, which is the best way to introduce inflammation, skin is a protective layer that prevents things from getting in the body. So if that layer is broken and there's tissue damage, the body will do everything it can to seal off the area damage so that these microbes or toxins can't move throughout the rest of the body. The other thing that inflammation does is prepares the site of damage for repair. So obviously we want to get tissue back intact to maintain homeostasis. So inflammation prepares the site where the tissue damage occurred to restore homeostasis. You all know the gold standards. I think you've probably done them in lab, but I'm going to go through them anyways. So the first is P, which represents pain that's due to the release of chemicals as part of the inflammatory response. R, which represents the redness that occurs around the site of perceived damage because of increased blood to the area. I is immobility that results in some loss of function. The body does deliberately try to limit function at a site of inflammation. S represents swelling. We get an accumulation of fluids in and around the damaged site, and you see this quite often as swelling of the tissues. And H, which is heat that comes from the increased blood to the area. So the amount of blood that's coming into the area brings heat with it, and you will touch that area and it will seem very hot to you. This whole prish, this results in the same response when there is damage, whether that's from a cut, so actual physical damage to tissue, burns, so temperature, radiation, which can be the sun, simple sunburn can result in an inflammatory response, or a bacterial viral invasion. There are three basic stages to the inflammatory response. Before we get into those three stages, I just want to talk briefly about something that is a wound and there is damage, but it works a different way because it doesn't elicit an inflammatory response. So the most apical layer of your skin is known as the epidermis. And sometimes we can get a damage done to that area that doesn't travel deep enough into the lower dermis where there's blood and so forth. So this is a wound that gets down as close to almost the dermis but doesn't involve it. So we say this type of wound may extend to the dermis. It results in only slight damage to the superficial epidermal cells. So this could be like a very shallow abrasion or a minor burn. This area will take care of itself, so to speak, without an inflammatory response. So what happens is you've got some damage to the epidermal layer. You will then get what are called epidermal stem cells that are within the epidermis. They'll start to surround the wound, around the edges of the wound, and then those epidermal stem cells will break contact with the basement membrane, remembering how important the basement membrane was to epithelial tissue, And then the sheets of the cells, once they break away, they enlarge and they start to migrate across the wound site as a sheet of cells kind of covering like saran wrap over the top of the cell. And they all start to enter from the migration, so they all start to enter from the wound edges in towards the middle. So as the cells come closer to the middle, they start to encounter each other. And when they do, coming from the other side of the wound, they will stop migrating and sort of just line up with each other. And this is known as contact inhibition. So they won't continue migrating, they just come up against one another and stop migrating. As the migration is occurring, there's also the release of a hormone called epidermal growth factor. And this epidermal growth factor stimulates basal stem cells that will then start to divide and replace those cells that have moved into the wound. So we have these stem cells, these epidermal stem cells that cover the wound. They are then replaced by basal stem cells, which start to turn that thin layer into a thicker layer, which basically results in new epidermis. So we say that these new basal epidermal cells divide to build a new strata or new layer, which results in thickening of the new epidermis. So those 3 steps of inflammation. We're going to use wound healing to speak to those different stages. It's just an easier way to work with it. Please remember that, inflammation can occur anytime the body perceives any sort of injury. So we have injury. The first thing is happening, of course, is stage 1. Stage 1 involves vasodilation and increased permeability of blood vessels within the area of the wound site. So when there is tissue damage, the immediate changes is an increased diameter of the local blood vessels. So any arterioles, now it is arterioles that go into capillaries. So those local arterioles will dilate. They will get larger in diameter. And of course, this will allow more blood into the area of damage. The other thing that happens is those capillaries that those arterioles feed, they start to get really leaky. So they increase their permeability, and this increase of permeability or leakiness allows normally retained substances that are usually just within the blood itself. They're allowed then to leak out of the vessel that's been, or the capillary bed that's been made more permeable. So there is a deliberateness to allow these the capillaries to get leaky into the area. The change in permeability allows immune proteins, known as antibodies, and clotting factors to enter the injured area. And of course, the immune antibodies are going to try to kill any invaders. And of course, if there's any bleeding that occurs, we want clotting factors to stop the bleeding in the area. This increased blood flow that happened in dilation also allows for the removal of toxins and dead cells as this process continues. So we can see here, we've got the damage happening, and we're going to see that we're going to have this movement because of this, things moving out of the bloodstream into the area of damage. The other thing that happens in stage 1, so we got increased permeability and increased dilation, vasodilation. We need to talk about what causes all that, and of course it's chemicals. So we have chemicals that are released in stage 1 when there's this tissue damage occurring. One of the chemicals that gets released is histamine. Now, histamine is found in mast cells, which are found in connective tissue, basophils, which are white blood cells, and platelets, and they all can release this chemical histamine. If you think about when you have a cold, what do you take, or allergic response, you take an antihistamine. What you're trying to do is lessen the inflammatory response, especially if you're having an allergic reaction to pollen that's in the air or something like that. Histamine causes vasodilation and increased permeability, which I just talked about, that vasodilation of the arterioles and increased permeability of the capillary beds. Another chemical that's released are known as kinins. Kinins arise from inactive precursors called kininogens. So we always have these kininogens floating around in our blood, but they're inactive. They're not doing anything until we end up with some tissue damage and this inflammatory process starts. So we say that kinins are peptides which are formed in blood from the inactive precursors kininogens. These kinins induce vasodilation and increase vasodilation. So now we have a couple of chemicals that's very much involved in increasing vasodilation. The other thing kinins do is increase tissue sensitivity. So if you've ever cut yourself and you wake up the next morning, the site of that little cut, even if it's a small one, it's quite sensitive. It's quite painful to touch and rub. And that is because of this one kinin called bradykinin. There's a deliberateness to make it a bit uncomfortable and painful so you don't go back to using it again or touch the area and so forth. The last thing a kinin can do is act as an agent to stimulate the movement of phagocytes. Remember, phagocytes are cells that eat into the area. So their kinins are going to stimulate movement of cells into the area. And in brackets here I have chemotaxis. Chem represents chemicals and taxis means to move. So this is the movement of cells because of chemicals. The next chemical we have in here are prostaglandins. And prostaglandins are released by damaged cells when the damage occurs and intensify the effects of histamine and kinin. So now we have a chemical that increases the effects of histamine and kinin. So, having that vasodilation and that permeability and all the things that kinins do, including causing pain, you can see that they're positively reinforcing each other to increase the inflammatory response. Prostaglandins also stimulate the movement of phagocytes through the capillary walls. So they're another chemical that causes the movement of phagocytes. The next chemicals are called leukotrienes, and these are produced by basophils and mast cells, so white blood cells are the basophils. And leukotrienes also cause increased permeability. So we've got lots of going on here that's causing vasodilation and increased permeability. So more blood to the area and more movements of things out of the blood system. Leukotrienes also help phagocytes to adhere to pathogens. So they act as a bit of a glue so that if there is a pathogen there, these phagocytes can stick to it and eat them, find it much easier so they can get them in their grip, shall we say, and then consume them. Leukotrienes also attract phagocytes from the blood system out into the area of damage as well. The fifth is what's called the complement system. And the complement system, exactly as the name says, it complements all these others to increase and stimulate the inflammatory response. So for example, complement stimulates histamine release, which then of course would further do what it does, attract neutrophils, which are involved, which will eventually become phagocytes within white blood cells. Complement also promotes phagocytosis, which will get them eating even more, such as bacteria. And also some complement chemicals can directly destroy bacterial, which have invaded the area. So we can see here, due to chemicals, we have the phagocytic leukocytes that are entering into the region that will munch away on anything that might be in here. Now, as we saw in the previous, pain is a prime symptom of inflammation. And this pain usually is a result from injury to neurons, because if we're stick a knife in a wound, we're going to damage neurons as well, but also the toxic chemicals that are released by the microbes who are in the area. So we've got, just the damage itself can cause damage to the nerves. And then if we do have microbes that are in here, they too can release chemicals that can stimulate discomfort and pain as well. As we just saw, bradykinin, for example, can stimulate some nerve endings and make them more sensitive to pain. Prostaglandins, they also intensify and prolong the pain and deliberately having it hang around. So again, we don't use that area very often. Pain can also be the result of swelling. So we have to understand that sometimes pain, if we get an accumulation of fluid into the area, and if anybody here has ever sprained an ankle, you get an idea of just how much fluid can accumulate in the area. As that fills up, it starts to distend the tissues. And one of the more sensitive causes of pain is distension. So if you get that swelling ankle, it's the distension of the joint capsule, for example, that can cause a lot of the discomfort. Along with the release of previous materials from increased permeability of the capillaries, we also see the release of clotting factors into the tissue to help blood clot. Stage 2. Stage 2 is known as the emigration of phagocytes. So within about an hour after this whole inflammatory process has begun, we start to see phagocytes appearing within the wound site or the damaged site. We see large amounts of blood obviously are beginning to accumulate because of all this vasodilation. And we start to see the arrival of the white blood cells called neutrophils. And they start to stick to the inner surface of the inner lining of the blood vessels, these dilated blood vessels. Because of the chemicals that we previously talked about, they attract neutrophils. So these neutrophils begin to squeeze through the wall of the blood vessel to reach the damaged area. This movement of these neutrophils leaving the bloodstream and heading into the area of damage of the wound site, this is known as emigration, and it is chemicals that drive that movement of these neutrophils from the blood system or the vessels into the area of damage. So this is why it's called chemotaxis. Chemicals are stimulating the movement of these white blood cells. These neutrophils use phagocytosis to destroy any invaders. So their whole role is to go in there and eat up as much as they can. We do get a steady stream of neutrophils into the area, and this is provided by the release of these type of white blood cells. These neutrophils are white blood cells, and they arise from bone marrow via something called leukocytosis. So this is why, sometimes when they think you might have an infection of some kind, and therefore then an inflammatory system process going on, the physician will take blood and measure white blood cell counts. And if there's a very high amount of white blood cell counts in your blood, it does tend to denote that there's likely some kind of infection and therefore inflammatory response that's occurring, hence the reason why there's so many produced white blood cells. So we can see here we've got eosinophils, monocytes, and neutrophils. All of these are a particular type of white blood cell. Here are the chemicals here that are within the area of damage, and it is these chemicals that attract these white blood cells to squeeze through these increased permeable capillary membranes to head into the site to help munch away at all these invaders. So we can see here that these these monocytes here, they're going through phagocytosis, they're going to munch away here and destroy these. The eosinophils, for example, they're also going to release chemicals that are cytotoxic. So just simply those chemicals that the eosinophil releases can kill the bacteria. So as the inflammatory response continues, monocytes follow the neutrophils as they're quickly dying off. So we can see here we've got the neutrophils go in first. They munch away as best they can as the initial one. Then behind them come the monocytes. Now the neutrophils aren't quite as efficient a phagocyte as the monocyte is, so they get used up very, very quickly, and then the monocytes will come in and continue phagocytosis. So as we say, as the inflammatory response continues, monocytes follow the neutrophils as they're quickly dying off. These monocytes that come in behind, they become wandering macrophages, which are more effective than phagocytes, in phagocytosis. So in other words, we're saying that the monocytes are much better than the neutrophils at eating up these invaders. The macrophages eventually die off, and then we start to see a pocket of dead tissue and phagocytes starting to build up at the wound site. The accumulation of this dead tissue and these phagocytes, this is what we call pus. So when we look at something as terrible as this, all this yellow material here is all dead tissue and accumulation of phagocytes that have eaten as much as they can of the invader. This is a prime example here of a significant infection. We can see a lot of prish here. I'm sure this individual is in a lot of pain. We can see a lot of redness. I'm sure it's immobile, it can't be moved. We can see the swelling here, and I'm sure if you put your finger on that, it would be very, very warm. As part of homeostasis, any damage to tissues must be repaired to ensure integrity from a protective to a functional return perspective. So we've talked now about tissue damage, bringing in clotting mechanisms, bringing in cells to help clean up the area, kill any invaders, and so forth. Once that's kind of done, everything is calmed down, shall we say, to some degree, and we've, shall we say, cleaned up the area of damage, we now have to repair. So repair is the replacement of worn out, damaged, or dead cells. New cells can originate by cell division from one of two ways. And this is kind of important to understand because it's going to come in a little bit later when you're working with things like scars. Stroma, this is a supporting framework of connective tissue. So stroma is connective tissue. Parenchyma are cells that constitute the functioning part of the tissue or organ. So with that in mind, if we wanted to repair a wound site, which would we rather repair? With stroma or with parenchyma? Stroma is what results in scar tissue. Parenchyma, we have cells that replace the damaged area that go on to continue to be whatever that tissue was when it was damaged in the first place. So stroma equals accumulation of connective tissue, and parenchyma constitutes cells that will return the damaged area into a functional part of what it was in the first place. Each of the four tissues have a different capacity for regeneration. So if we remember the four main tissues of the human body. Epithelial tissue has a high capacity for regeneration due to the nature of the sloughing off of these cells. So because epithelial cells are constantly regenerating and replacing themselves, any kind of damaged epithelial tissue usually heals quite quickly and usually returns back to normal without any kind of problem. When we look at connective tissue, some connective tissue have a continuous capacity for renewal, such as bone. So cartilage and tendons cartilage and tendons less so due to the small blood supply. So when we look at cartilage and bone, they don't heal quite as well as epithelial tissues because they don't have the full blood supply like epithelial tissues do. The third is, of course, muscular tissue. It actually has a poor capacity for regeneration as muscle cells are slow to divide. So in some cases, this is why we get scars in the deeper structures like muscle damage, because this poor regeneration of muscle cells. Cardiac cells do not undergo mitosis at all. So if we have damage to the muscle cells in the heart, they always replace themselves with connective tissue. So if you have a heart attack, a myocardial infarction, this is a type of heart attack where certain areas of cardiac muscle has died. It then heals, but where that muscle was is replaced with connective tissue, which means that part of the heart can no longer contract. So now you can imagine that if you have a very large heart attack and there's a large area of myocardial cells that are destroyed and replaced by connective tissue, then that heart and that individual becomes relatively inefficient. And of course, then the larger the area, the more inefficient the heart becomes. And then if you get enough significant damage to the myocardial cells, then of course the heart can't function and the patient is likely going to die. Nerve tissue has the poorest capacity for regeneration as they normally do not go through mitosis. So when it comes to healing, damage to nerve is somewhat limited in its ability to heal itself. So with these couple of things in mind, stroma, parenchyma, the types of tissue, the restoration of an injured tissue or organ to normal structure and function depends on whether parenchymal cells are active in the repair process. So that's the most important thing to understand, is that when we are looking at trying to get tissue repair appropriately, we want the body to have parenchymal cells stimulated in the repair process. For a near perfect reconstruction to occur, parenchymal cells must accomplish the repair. So if we wanted to return back to where it functionally could work, we want these parenchymal cells in the repair process. If fibroblasts of the stroma are involved, the replacement tissue will be connective tissue. In other words, a scar. So if in the repair fibroblasts get used rather than parenchymal cells, we get connective tissue, which we know as a scar. So what happens is, if fibroblasts are utilized in repair, these fibroblasts synthesize collagen, and that collagen all comes together to form scar tissue, and this is known as fibrosis. So if you get scar tissue from a wound, it's known as fibrosis. So you're going to start to hear that in terms of the scars being fibrosis. And because it's not parenchymal, this tissue will not have the same properties as the original tissue. So when we have scar tissue that's formed as the repair process, it's not going to function like normal. So if it is a muscle, for example, it's not going to stretch. It's not going to contract. If you've got burn of the skin, so the skin's been burned and you get scar tissue, that skin is not going to be able to stretch. If someone is significantly burnt on a limb or back or whatever, their range of motion is significantly limited because this scar tissue does not have the same properties of skin and cannot stretch and move like the skin that was damaged. So you have to remember that whenever you see fibrosis, you know that it's happened. I have a little side story for you. I did have my one shoulder repair done, and I got a post-surgical infection, and it didn't heal well at the beginning, and I was on lots of antibiotics and so forth. But when I finally went to the surgeon to see how it was doing, after I'd been to the hospital here in Barrie a few times with all these infections, he opened up the wound site, and because it had split open because of the infection in it, and I was watching him, and he took a pair of tweezers and he pulled what looked like a spider out of my shoulder, this white spider with all these extensions. It was, think of a small body, like a large body, and these extensions moving out in all directions. And I said to him, I said, is that pus? And he said, no, it's fibrosis, it's connective tissue. And I could see directly what happened was these fibroblasts and this collagen, this aggregation, it looked like literally a spider with all these hands reaching out to grab other tissues, and it all pulls it in and makes it pucker. And we don't want that. Sometimes you can't avoid it, but again, thinking about parenchymal versus stroma, stroma equals scar tissue, known as fibrosis, and it doesn't have the same properties as the tissue it was replacing. So we can see here a couple different things. This was likely a surgical scar, and this is why we stitch wounds together, because yeah, although there's some minor scarring here of these stromal cells, underneath is likely pretty normal. Parenchymal cells were probably involved in the repair underneath. We do have a couple of fibrotic tissues here, or scars. We can see in this one, likely what happened was, you can see the stitch points here, or staple points. Somehow this wound split apart, and you can see the edges of the incision on either side, and all this pinky material, tissue in between, is all fibrosis. And you can see the lines of collagen, and you can see how the collagen started to pucker in around the wound. And again, this is not skin tissue, so it's not going to stretch the same. This looks like a burn to me, and you can see here again, we've got stromal cells involved, and you can see all these strings of collagen kind of intertwining and sort of connecting, disconnecting. And again, we're not going to get the same kind of movement of this tissue as we would if it was nicely together like this. In extensive damage, such as a large open wound, both the connective tissue stroma and the parenchymal cells are active in repair. Now we're talking a fairly extensive wound, a very deep, large wound. The fibroblasts, remember the fibroblasts are related to connective tissue, they divide quite rapidly, and we end up with new collagen fibers, and this helps provide some strength to the wound site. Now within the wound, because everything's kind of large and separated, you start to get capillaries that are created, so they sprout these new buds because they need to start supplying blood to the tissue as it heals. The fibroblasts, collagen fibers, and these capillary spouts and their growth, these create an actively growing connective tissue, which we call granulation tissue. This tissue forms across the wound, and it provides a framework, stroma, that supports the epithelial cells that will migrate into the area and fill it. And because it's connective tissue and fibroblasts, you get a significant amount of fibrotic tissue that's created within it. So when I talk about a large wound, this is what I'm talking about. These are likely burns, in some cases, or maybe even what we call an ulcer. We'll talk about it a little bit later on, but we can see we're talking extensive tissue damage here, right? There's no way to bring these wounds edges together to fill in the spot. So we need that. You can see that what we're looking at here is granulation tissue, and it slowly grows, shall we say, from the bottom to the top, or from deep to superficial. And yes, this is a bone that you can see right here that's been exposed. Here in the back of the hand, the same thing. Here's our wound edges here, and we can see this is all granulation tissue. So when we look here, we can see that when we want parenchymal cells involved, we can see that the cell edge, the tissue, damaged tissue edges, they get joined by fibrin, which becomes fibrinogen. Fibrinogen becomes fibrin, which forms the clot, that hard, crusty thing you see on your hand or your arm when you cut yourself. And then what happens is once that sort of brings the edges together, we start to see a regrowth of basal layer cells of the epidermis starting to fill in the spot here. Again, this would be connective tissue, fat down here. This would be, this would be connective tissue. Then we've got our layers of the skin here. You get this lysis of fibrin and re-epithelialization of the tissue here. Eventually, everything disappears and you just get intact skin and it looks perfectly normal. When we have a deep wound, you get a large fibrin clot that fills in the wound site. New blood vessels and fibroblasts grow from the dermis into the fibrin. So this is the big difference between the two. You get this granulation tissue that's forming, and it grows from the dermis into the fibrin. You get collagen that's laid down by this granulation tissue, and it's trying to restore integrity or strength to the area. And the only way it can do it is by releasing this fibrous and creating this fibrous scar. And then you get maturation of the collagen, which does achieve structural integrity and allows some growth of the epidermis, but in a way that it's not back to normal. So when we look at this, what I want you to take away, in growth here, I talked about stromal healing and parenchymal healing. Now, parenchymal healing, of course, is the top one in this slide, and then, of course, stromal healing is the second part of this slide. The other way that this is known that I always used, when we have parenchymal healing, this is known as primary intention. And when we have stromal healing, this is known as secondary healing or secondary intention. You must remember both names because you're going to come across it, okay? So primary intention or primary healing is parenchymal, and secondary intention or secondary healing is stromal healing with connective tissue and fibrosis, okay? And you're going to do a whole section on scars coming down the road in other semesters. So when we look at tissue healing, there are three factors that actually affect tissue repair. The first is the nutrition of the patient. Second is the blood circulation in the area. And the third is age. Now, I know there's a couple of PSWs and practical nurses, I believe, in our program, and they're going to know all about this because this is somewhat associated to, shall we say, pressure sores, those sorts of things that we see in long-term care. So I will be talking about that a little later on. But the thing you have to remember about tissue repair is nutrition, blood circulation, and age. It plays a vital role in it. Thanks for listening and have a great rest of the week. Hopefully I will see you guys on Thursday.